بسم الله الرحمن الرحيم. السلام عليكم. الحمد لله والصلاة والسلام على رسول الله. Thank you very much, Dr. Hanan, and the organizing committee for inviting me. I'm so pleased and honored to be here with you today. I'm going to actually talk about the, have some touch on the definition of refractory lupus nephritis, the factors that we need to consider before diagnosing patients with lupus nephritis, the challenges that we may actually encounter in the management of refractory lupus nephritis, and we'll just have an overview of some available evidence backing the current management. So the definition actually of refractory lupus nephritis varies between the associations and in the literature, to be honest. I'll just, focus on KDIGO and EULAR. KDIGO is the Kidney Disease Improving Global Outcome Guidelines, and EULAR, as you know. So in KDIGO, they define the non-responding lupus nephritis as failure of attaining the complete or partial remission despite of being on standard therapy, complete remission having proteinuria of less than 0.5 gram per gram from a 24 urine collection. It's not a random spot urine, from 24 urine collection. The idea behind that is to make sure and to overcome any possibility of variation in the creatinine excretion in the urine that may happen during the daytime. Partial remission is defined as having a proteinuric reduction by 50% at least, and protein to creatinine ratio of less than 3 grams per gram, given that the creatinine level in the blood is stable or improving. Failure to achieve that is considered as refractory or no response at all. Does that mean that we have to wait for 6 months until we know whether the patient has complete remission or partial remission? Actually, we have to have a follow-up of our patients, and we should see some improvement in the first 3 to 4 months, or otherwise, we may actually act accordingly, all right? So, okay, how about having severe disease with no response at all, or worsening kidney function in the first 4 weeks of treatment? In this case, we will regard this as failure, and we will actually intervene early as the first 4 weeks. In comparison with EULAR, failure to achieve the treatment goals, and the treatment goals is defined as stabilization or improvement in the creatinine, and having at least 25% reduction in the proteinuria by 3 months, 50% reduction by 6 months, and in 12 months' time, you have to have complete remission, i.e. urine protein to creatinine ratio of less than 700 milligram. All right, before you diagnose patients with refractory lupus nephritis, we have to, and we know that, but let me remind you that non-adherence does not mean refractory. If your patient is not adherent to the medications, he for sure will have an active disease or maybe relapsing disease. And in such cases, we don't call this a refractory. Is it a major issue in lupus patients? Of course it is. Actually, in this study that was published in 2018 by Sweda, Prof. Umair and Prof. Abdelkarim Sweda, they found that the rate of non-adherence can be as high as 62% in patients with SLE. In another study that included data of more than 4,000 patients, they found that the non-adherence is actually quite common. The only adherent patients were less than 22%. So we're talking here about really a major issue in the management of SLE, particularly lupus nephritis. Adherence, non-adherence does not mean refractory. Okay. Any useful tips for evaluation of the compliance and adherence? Yes. One, absence of steroid side effects. Two, not recalling the number of the pills. Patients on steroid of, let's say, 50 milligram. He or she is supposed to take 12 tabs of 5 milligram. When you ask the patients how many tabs you're taking, if the patient pause a bit and start thinking, that probably means that the patient is not really taking the medication properly. You could also track that by knowing and reviewing the refill records, and also by monitoring the drug levels if that is available. Okay. Any pitfalls? Yes, pure membranous nephropathy behaves differently. Class 5 pure membranous nephropathy behave differently. How? It actually responds very slowly to the medications. In one of the studies that used MMF as a monotherapy for for class 5 membranous nephropathy, they found that actually they respond gradually. Most of the remissions, partial and complete, started to be there after 7 months of therapy. And this is almost consistent, in the studies, in the small studies conducted on pure membranous nephropathy. And because of that, there is a comment from the EULAR with regard to those patients with nephrotic range proteinuria, lupus nephritis with nephrotic range proteinuria. They stated clearly that we may need actually an additional 6 to 12 months over the previous 6 to 12 months in order to reevaluate and assess the patients. Why? Because we see actually complete response after 12 months sometimes in pure membranous nephropathy. And we may see partial response after 6 months of membranous treatment of membranous nephropathy. Okay, any challenges? Yes, no good data on its management. It's largely all what I'm going to talk today about is largely based on uncontrolled observational studies. And because of that, you see, different approaches, different variation between physicians when they treat refractory lupus nephritis because of lacking the data. Any other challenges? Yes, definitions, as I said before, varies between in the literature. As an example, in this meta-analysis and systemic review, they found, if you look at that, in addition to steroid, some of the studies regarded one immunosuppressant in addition to steroid with no response is refractory. Other studies said, no, you have to have 2 other immunosuppressants on board in order to call it refractory. Others say, no, you have to have 3 immunosuppressants at least to call it refractory. And in other studies, there was no clear data about the treatment that being used. Okay, so what we do? Well, based in KDIGO guidelines and EULAR guidelines and the Saudi guidelines that was published recently, we switch from MMF, if the MMF is the first line used, to cyclophosphamide. Or vice versa, we switch from cyclophosphamide, if the cyclophosphamide Eurolupus protocol is the first line used, to MMF. However, this is not really based on good quality data. How about rituximab? Well, here a meta-analysis done by our colleague from Jamiat Al-Qura, Dr. Fatma Sheikhi, 1,000 patients in 31 studies. The lupus nephritis were found to be in 10 studies with 223 patients. And this study showed that rituximab actually achieved up to 51% complete remission and 27% partial remission. That's really very good. In addition, rituximab showed a significant corticosteroid sparing effect through a marked reduction of prednisone dose in both SLE and lupus nephritis. Another study, another systematic review, that included 26 studies with 300 patients. They found that the complete response is about 40% and the partial response is about 34%. Again, another good systemic review about use of rituximab in the refractory lupus nephritis. In this systemic review, they found actually this observation where no clear definition of refractory lupus nephritis in the literature. Okay, let's talk about other medications. How about multi-target therapy? MMF, steroid, and CNIs. Well, again, we have pilot studies, low quality evidence of small data from observational cohorts suggested that multiple or multi-target therapy is of good benefit in patients with refractory lupus nephritis. How about voclosporin? Dr. Hanan, she just mentioned the Aurora study. We have an evidence that voclosporin as an add-on therapy is better than the standard therapy in inducing active lupus nephritis. But do we have evidence for voclosporin in refractory? Not yet. Not yet. Will you use it? Will you may consider it in those patients? Yes, I may consider it. I have a study of 260 patients that showed benefits in inducing lupus nephritis with good safety profile. So yes, I may keep it in my mind, but I don't really have the evidence that support its use in refractory, but in active lupus. Okay. How about adding belimumab? Dr. Hanan just showed us the BLISS-4 study that showed benefits of belimumab. Again, that is in active and relapsing lupus. Will we apply the same for refractory? From evidence point of view, we don't have evidence to support that. Shall you use it? You may consider it. We have a data from 400 patients that showed a safety profile at least for belimumab. Okay. How about combining belimumab and rituximab in refractory cases? Well, in lupus nephritis, we don't have evidence to back this up. We have pilot study that did not show an additional benefits of belimumab on rituximab, but again, we have to have good randomized controlled trials to be sure about that. Okay, what is the approach? This is the approach of Saudi guidelines that was adopted from the KDIGO and EULAR. We first make sure that we actually our patients are adherent to the medications, and in order to ensure this, we have to consider, as I said before, the number of refilling, etc., and the drug levels if that is available. You may consider kidney biopsy in non-clear cases. For example, if you're not sure whether this disease is, whether this proteinuria is more of chronic changes rather than acute, or if you may consider actually another pathology like microangiopathy, then you may proceed and do kidney biopsy. As we said, switch the first line from MMF to cyclophosphamide or from cyclophosphamide to MMF, then you consider the other medications like multi-target therapy or including voclosporin or belimumab. Okay, any other medications that's been tried in refractory lupus? Yes. I'll talk about here the pertuzumab. Pertuzumab, it's been used in myeloma, right, with dexamethasone. It depletes plasma cells. If you are able to deplete plasma cells, you basically decrease the production of autoantibodies, and you also decrease the dependent activation of T cell pathway, and you also decrease the induction of interferon alpha. So that was the rationale behind using pertuzumab and dexamethasone in refractory cases. As you see, it was tried only in a small number of patients, and the result was not bad, to be honest. The partial response rate in the first study was not bad, And the complete response rate in the second study was not bad too, but the number of patients in these two studies were 18 only. Okay. Anti-CD38, the daratumab, well, it's only tried on 1 or 2 patients, so we cannot withdraw any solid conclusion out of it. Leflunomide, been used in 17 patients. We might consider it. It targets lymphocytes, but again, it's only 17 patients. These are not, it shouldn't be the first or second or third line of therapy. It's like rescue therapy in severe life-threatening cases, let's say with very bad refractory lupus nephritis, maybe, I would say. IVIG has been tried. The idea of giving IVIG is to neutralize the autoantibody and also to increase the clearance of autoantibody through the reticular endothelial system. It's been tried. The result sounds promising, but again, the number of patients was not that good. Anti-complements, eculizumab, you know, in SLE without macroangiopathy, we have no good data about it. There are few reports about eculizumab as an anti-complement therapy in patients with lupus nephritis and microangiopathies. Okay. How about autologous stem cell transplant? By this, I will do reset for the bone marrow, right? I will reset the production and the immunological system, basically, and I will deplete the autoreactive memory of the bone marrow. Okay, I think that's a good idea to think of. Do we have an evidence? Yes, we have 22 patients of a study that was published in 2019. And in this study, actually, found that the response rate was actually complete. 18 out of 22 did have complete remission. 1 out of 22 did have partial remission. So that's really an excellent, rate of remission, to be honest. However, 2 deaths happened. 1 death during the first month, so they related that to the transplant itself. And another death happened at 3 months due to pulmonary infection. So we have 2 deaths out of 22, almost 10%. Number one. Number two, we have a relapse rate of 27%. And the earliest relapse happened at 13 months, after 1 year of the bone marrow stem transplant. Is it worthy? If you have a high, relapsing rate, or if you have a high, relapsing rate and significant, I would say, mortality rate, will you go and do transplant? Because of these side effects, we're holding off on the autologous stem transplant for SLE. But, you should keep it always in the back of your mind.
You have 1 minute.
Sure. So in summary, management of refractory lupus nephritis varies between the physicians. Why? No good evidence. You may switch to cyclophosphamide or MMF and vice versa. The experience from systemic reviews and meta-analysis may favor actually rituximab, as the data for other agents is limited. No well-designed RCT comparing the effect of these different agents in refractory lupus nephritis. Thank you so much.